Good afternoon, everyone. It is my great pleasure to welcome you to this inaugural webinar in our series, Nurse Education and Leadership, the Yin and Yang of Timely Palliative Care. My name is Camelia Ancuta, and as a president of the APC Task Force on Innovation and Nursing Education, I'm delighted to open this session alongside with my colleagues Heidi Defloor, who is the Vice President of this task force. This webinar marks the beginning of an educational journey, a series of webinars designed to empower nurses, nurse clinicians, and nurse educators through different learning experiences. These resources will contribute to the spread of dynamic and immersive educational materials aimed to increase knowledge and to develop self-efficacy and the critical reasoning skills required for clinical practice and leadership role in palliative care. As nurses, we navigate the complexities of palliative care day by day, balancing between compassionate caregiving and the requirement of the advocacy and leadership. We still have the disparities in education and training, and the opportunities to strengthen our leadership skills are still unequal, and the objective of this task force is to enhance nurses with the skills and confidence to lead, educate, and inspire changes. Heidi, please.
Thank you, Camelia, and a warm welcome to everyone joining us today. My name is Heidi Defloor, as Camelia said so, and as Vice President of this task force, I'm inspired by the mission we are building together. Our objectives are ambitious, yet vital: to build an international community of nurses and educators passionate about advancing palliative care, to share and disseminate insights from ongoing projects contributing to nursing education and leadership, to create and implement an immersive framework for education aimed at fostering leadership skills that empower nurses to influence change in their communities and beyond. This series of webinars, starting today, will be a cornerstone in creating the tools and content to achieve these goals. Together with the members of our task force, we will teach and talk about learning materials that activate and inspire, helping nurses develop the knowledge and confidence to take on roles as clinical, professional, and moral ethical leaders in palliative care. All webinars will be recorded and made available through our website, the NursEduPal Impact Project website. Next to you, Camelia.
Thank you. We are honored today to have three exceptional speakers who embodied the values and mission of our task force. One of them is Dr. Julie Ling, former president of the APC and now technical officer palliative care in the World Health Organization, Europe, whose advocacy and leadership have shaped palliative care nursing globally. Then we have Professor Phil Larkin, also a former president of the APC and professor of palliative care nursing at University of Lausanne, a visionary whose research and practice continually inspire innovation in nursing education. Closing today's session will be Vereecke, our project coordinator of NursEduPal Impact. Danny's leadership ensures that the vision of the task force is also implemented in the ERASMUS project.
Thank you. To everyone here today, this is the beginning of a shared journey. Through this series of webinars, we aim to provide you with tools and insights to strengthen your ability to lead, educate, and advocate. Together, we can strengthen palliative nursing and empower palliative nurses. Thank you for your commitment and your passion to be here. Now it is my honor to introduce our first speaker, Dr. Julie Ling, President of the WHO, Technical Officer, excuse me, of the WHO. Please write the questions you may have or your comments in the chat. After the 3 presentations, we will have a Q&A session where we will address the topics mentioned in the chat. Thank you.
So hello everybody, you can hear me okay? Okay, yeah. Good, I'm getting nods. Hello everyone, so I'm Julie Ling. Many of you will have known me as CEO of the European Association for Palliative Care for the last 10 years. I recently moved to Copenhagen to be the Technical Officer for Palliative Care in the WHO European region. And I guess, why am I speaking about palliative care nursing and leadership? Because firstly, I'm a nurse. And I guess when I was in the EAPC, I needed different skills, and lots of our nursing skills that we learn and that we have developed over the years are really transferable into any post. But I think management and leadership can be quite a challenge to everybody. And so whilst I was working at the EAPC, I undertook an MBA, which was an experience, but a good one. And I think possibly something that helped me realise that as nurses, we have some really, really valuable skills that perhaps others haven't got. We're great communicators and we multitask, and there's lots and lots of things that we do, and that we really are ideal leaders. So I think it's something that I'm quite passionate about, and I'm really grateful to have the opportunity to present here today. I can see in the chat there's lots of names I recognise, so if you've heard this talk before, I'm very sorry, and if you haven't, then I hope you enjoy it. So let me see if I can find the next button on my slides here. Okay, so stealing from my time in the EAPC, I've divided up this session, so palliative care, nursing, leadership, and then I'm going to put them all together at the end so you understand what I'm talking about. So this picture won the best photo competition at the EAPC Congress in Rotterdam, and I just think that it's a really good visual description of what palliative care is, and it's where we adapt and make things happen for people at the very end of life, but all the way up to then too. And so I think this is a really good picture, and I particularly like it. So I know many of you work in palliative care, but I start nearly every talk with this slide because I think we all say palliative care, but sometimes we mean different things. And so sometimes it's a good reminder to say, well, what are we talking about? Why are we saying that palliative care is a good thing? Because palliative care it really improves quality of life, and it benefits health systems. It can save money by using resources better, but also improving quality of life for patients and their families. It can be done by many healthcare professionals and volunteers, and of course it should be. So we know that no one healthcare professional can take care of what everyone patients needs, that we need a team, and that's the best approach. And it's for all people with life-threatening and life-limiting conditions, regardless of their age, so across the lifespan, from neonatal care right the way through to old age. We know about it treating pain and physical and psychosocial and spiritual suffering. And I think it's just a good reminder. If any of you teach, you can borrow this slide. So the World Health Assembly resolution, which was now 10 years old, was unanimously passed by the World Health Assembly. So why is that important if you're working in clinical palliative care? It's important because the World Health Assembly is the decision-making body of the World Health Organization. So they're the ones who rubber stamp everything. And why is this important? Because The WHO Europe stretches from Portugal in the west right the way across to Russia in the east and encompasses 53 countries, or as they're known, member states, and they all sign up to this. So everyone in this region has signed up to say that they will strengthen palliative care, and that it will be something that the Ministries of Health will work on and will develop. So we're now 10 years on from this World Health Assembly resolution, which was a really big landmark decision for all of palliative care universally. So, and I think, has it had a huge impact? I'm sure many of you have worked in palliative care for the last 10 years and would know some advances have been made, but perhaps things haven't improved as much as we'd hope. And so it's important when we're looking at leadership, because obviously that's how changes occur, is through us and our leadership as individuals and as parts of teams. So evidence suggests, and there's strong evidence, this is not just me saying, that it improves quality of life of patients and caregivers, decreases symptoms, increases opportunities for patients to die in their location of choice. That said, I just saw a recent report from the OECD which said that still 51% is the average of people still dying in hospital, when perhaps that isn't where they want to be. It's cost effective, as I said, and can really help to save costs on the health service, and also prevent patients from having multiple tests and trips to hospitals and so on. So it's interdisciplinary care. This, sometimes we know, working in palliative care, how important this is, but actually a lot of people in other specialties don't understand that palliative care is interdisciplinary. And I think we have to realise that it's a whole range of services, it's a whole range of professionals across different specialties. So, for example, cardiology, pulmonology, all different specialties, palliative care, but it's also the team working in palliative care who provide these services, so including physicians, nurses, pharmacists, physiotherapists, volunteers, really important, and not just volunteers who they need to be trained and included in the team. So this is the model of palliative care that the WHO uses, which is really, I think the foundations are really strong. So it's about empowering communities and empowering people to understand what palliative care is. There's a lot of work, obviously, we know about people being able to make decisions. There's work on advanced care planning, compassionate communities, and these are all things that fit really well into this model. We need it to be included in health policies. So how does that happen? That happens because policymakers don't just pop it in because they think it's a good idea. They put it in because it's part of the World Health Assembly resolution. They put it in because they start to realise that palliative care is important, but it needs to be not just a standalone palliative care policy, but also policies that relate to palliative care. So, for example, we look at people with neurological or respiratory conditions who need palliative care, and so it should be included in policies that relate to those too. We need really strong evidence, and I think this is where we still fall down despite massive investment from the EU. I think when I was at the meeting in Belgium earlier this year about innovations in palliative care, they said they'd invested 100 million euros into palliative care research over the last number of years. And it's about not just having this research, it's about how do we implement the findings and how do we implement this best evidence, which is what we need. There's huge swathes of the European region that do not have access to essential medicines. So that's still a big issue that we need to address. Education and training is the way forward. If we educate and train our health workforce, then they'll be able to deliver, and it needs to be included in education for undergraduates and postgraduates. Palliative care is missing from many curricula. And not only that, we then have, just to add another layer of complexity, a really big crisis in the health workforce at the moment in the European region, with huge migration of all healthcare workers. And I'm going to talk more about that as this goes on. And then obviously we need to integrate palliative care early to ensure that people get the best care possible. And of course, as with all things in palliative care, the patient and their family and those who need palliative care are at the heart of everything we do. So this is really, I promise you, this is a book from my library as a child. So The Nurse. So this is from 1966. So apparently, and this is my favourite bit, The nurses carry out the doctor's orders and care for the patients until they're well enough to go home. So this is what we were taught as children, that if you're a nurse, it's a job that you do. You work in hospitals with sick people and you help them to get better, or everyone gets better. And then you do what the doctors tell you to do. So I think nursing has changed, thankfully, over the last 50 years. So facts on nursing: there's 28 million nurses worldwide and a huge shortfall. As I say, there's a crisis, and there was a document published last year from the WHO Europe that showed that in 19 of the 44 member states who answered a questionnaire, something like 80% of their GPs were over the age of 50. So they're all going to retire. So we need to look at different models, different ways of working. And nurses are the largest occupational group in the healthcare sector. So you can see we're the largest, but we're not the most powerful in many ways, which is always, I think, something we need to think about. There's a really big deficit in low middle income countries, and that's because of this kind of brain drain where people from Western Europe who can pay better salaries recruit from countries where perhaps they don't have good salaries, and people move for a better salary and a better way of life. And then of course in Western Europe, people are recruited to Australia and New Zealand. So it's this kind of like global migration of not just nurses, but predominantly nurses. And you can see that this brain drain is not exclusive to nursing. I'm sure many of you already know this in your own practice. So nurses and midwives, 61% of practicing health professionals in the WHO region, 89% are women still. And we're trying to improve care, and also I think what I would know from my role here in the WHO is that nursing doesn't mean the same thing in every country, and nurses are treated very differently in different countries and have different levels of education. In some countries, nurses would definitely be a doctor's assistant, maybe provide meals, wash patients, but not do any clinical care really very much apart from that. So there's a really wide variation of roles. And then in many countries now you can have PhD nurses, so it's not uniform across the region. However, our Director General would say that nurses are the backbone of the healthcare system, and I think we can all agree to that actually nurses provide the majority of care and are the ones who prop the whole healthcare system up. So gender issues prevail. So we know that there's huge pay gaps in nursing, there's inequality, minimum wages, there's discrimination in promotion and leadership. And I know even amongst the panel, when I was looking at the start of who was going to speak, that Phil is the only male amongst all of us that was talking, and we're talking about nursing. So I think, you can see that there's still that thing where perhaps promotion and leadership and decision-making positions in nursing, still quite a few of those go to men rather than to women. And that's something that prevails even now in 2024. So this technical briefing from the WHO Europe was looking at how we could promote nurse leadership. One of my colleagues here, who's the Chief Nurse for Europe, has set up a Chief Nursing Officers group for the whole of the European region, and they meet regularly to discuss, issues and to work on various plans and documents to see how they can help to recognise the essential role of nurses. And obviously, there's huge variations, but quite a lot. So in this region, there's 4 official languages, but you've got 900 million people, and you're trying to look at countries that have very different cultures and contexts, and nursing is viewed very, very differently in each of them. But yet this group has come together because they recognise that perhaps they're stronger together. So leadership. So having undertaken my MBA, I suppose leadership became something we had to reflect on ourselves and our own styles of leadership and think about what leadership actually is. And I suppose my very simple description of what leadership is: if you're a leader, people want to follow you, otherwise you're not really a leader. So I think this is something that's the Julie Ling philosophy. So there is this whole thing that you're either born with leadership skills or you're not. And I think, we probably all know this, even within our own personal lives, in our families, you know, maybe we have siblings, or, you know, someone's bossy and tells you what to do as a child, and are they the leader? Or anyway, so, but I think research has moved on from there, and you can see from this business paper, not from nursing, this is bringing in literature from outside, and I think that's what's important, is that we look outside of nursing to see how things work. But leadership is, you get better through training. So how many nurses are trained in leadership? How many nurses have modules where they're actually told about leading and development and advocacy and all of the things that we really need to be able to do? And I think that's probably not many of us. I think I had a management module, which meant you had to be able to manage a ward of 30 patients and make sure they all got to theatre on time. That was the management. Whereas I think what we're talking about here is a much broader concept of looking at how we can influence people outside of our immediate sphere and show them what nursing is. And I think that's really important. So if you want to manage yourself, you need to look in the mirror. So what are we saying? Are we role models for good leaders? Are we leading ourselves? Are we able to manage ourselves? So what do we do? Do you look at your time? Do you manage yourself efficiently? How does your day look? Do you respond to changes and think about opportunities? Are you caught in the lift with somebody, I don't know, the manager for palliative care services? Do you use that opportunity to talk to them about development of palliative care? Or, I mean, I think sometimes it's using these opportunities. Are you able to be composed? You don't get cross and lose your temper. Do you know what your weaknesses as a leader are? For example, some people find it very hard to say difficult things. I think we all do, but there's nothing more difficult than trying to tell someone that their family member is dying, and yet if you have to tell a colleague that they did something wrong, that can be much harder for us, because it's not something we're trained to do. We need to be able to give that news in a way that's acceptable to a colleague, or if you're a manager at whatever level, you need to be able to look at how you communicate with people. And do you have a support system, and do you use it optimally? It's not always a work support system. It can be your personal support system too, but everybody needs support at some point. So managing others. I think of everything in my career, and I'm not that far from the end of my career, that is most difficult is managing other people. And I think this can be, it is so difficult to do it well. And for those people who do, I mean, I'm sure if you think back, you can all remember somebody who you thought was a very good manager or a leader. But it's definitely not everybody that's ever managed you that you think is good. So do you respond to team members? Do you motivate people? Can you address conflicts? That difficult thing we spoke about. Can you handle situations with empathy? Because sometimes, you know, you can say something that's difficult to say, but if you say it with empathy and understanding, it can be delivered much more easily. Do you work well with other people? Do you know what your team's strengths and passions are, and so that you can get results? And I guess the opposite to that is, do you know what perhaps people don't like doing or aren't as good at and maybe need to have some help developing? Do you have blind spots? How would you know? That's by only looking at yourself. Can you know if you have those, and looking in detail at yourself? And does your behaviour inspire trust in others? I mean, if you want people to follow you and you're a manager and a leader, then they have to trust you. And I think that's really important. So assessing your team performance. So yeah, you need long-term goals. We all need to know, are we all on the same page? Some people say it's the same bus. You know, you're all sitting on different seats on the bus, but you're going in the same direction because you have a strategy and you understand what your long-term goals are, and are they realistic? And how do you achieve them? You want high quality resources, you need support networks. Can you make quick decisions? And sometimes this is really important. You know, that there's something that requires attention immediately and you don't have time to sort of mull it over. What I would say in these circumstances is you always have a few hours. Don't ever say anything immediately that you're going to regret. That would be my advice. But certainly you have to be able to make a decision quickly. And also you need to lead and spearhead change. So people will be looking to you to see, can you help with this? So leadership versus management. So this is the differences, and this is from the Harvard Business Review. So you can see again, taking from the learning from outside of palliative care, outside of nursing. So management's about control, but leading is about inspiration, and that's what sets you apart, and people wanting to follow you. It's not about power and control. It's that they know you know what you're doing, and they trust you. And I think there's very separate things. A lot of people can manage, but quite a lot of people cannot lead, and I think that's a distinction. So why do I always show this slide? I show this slide because Sheryl Sandberg worked in Google, and when I was doing my course, I was reading this book, and one of the things she said is that it's a gender-based assumption that if you give a man and a woman a job description and you say to them, just go through this and tell me what you've got, you know, have you got all the essential criteria, that men will say yes to most of them, but women will go, oh, I only did that once, I don't know if I have that experience. And it's about confidence and competence, so that in a way, women perhaps often don't sell themselves as well as they should. That's not me saying that, that's from the book. But in a way, by showing the slide, you know that I kind of believe that too, that we as nurses, and predominantly women, we know 89% are women, that we actually don't always sell ourselves right. And so, for example, if we're going for a job, do we always think, oh no, well, I won't get it? Whereas perhaps someone else who's male, who feels they have all that experience, will be able to say, well, I have everything. So interesting book if you're looking at anything around gender-based management, all of these things. A very good book to read. So basically what we need to do, if we can, is marry leadership skills, a clinical background. This is the perfect thing. So throughout my career, I still think back to my nursing days, and I haven't clinically nursed for a long time, except for vaccinating during the pandemic. But basically, you need to think about your clinical days, and I remember those every time when I'm looking at any other work, even now here in the WHO, when I'm giving talks or visiting. So, for example, I get to go and visit different organisations, and I will go and I will see, and I think, oh yeah, I can. You know, I don't know how many palliative care units and wards I've seen, but I bring with me my clinical head as well as everything else that I have. So, if we marry all of them together, I guess, and I've only got a few more slides because I'm running over a little bit, but I guess I'm going to show Cicely Saunders and say that she was the original one-woman multidisciplinary team, but a nurse, a doctor, and a social worker. So she cannot have separated herself from the nursing skills she acquired when she was doing her training. And so they were with her during all of this. And I can't help but think that as a nurse, palliative care and nursing are so closely aligned in their goals that actually she took a lot of that learning with her through her life. So leadership should be about empowering all members of the team. If you are truly a multidisciplinary team, it's not about one person always being the leader. Others have the leadership role at different times. And I think that's important to know as well. It's not always the doctor that has to lead. It can be the nurse, and it can be the social worker at other times. It doesn't have to be just one person because of their profession. So strong leadership, we need to improve quality and reach of palliative care at end of life. So this is our role, advocacy, to make sure that we improve palliative care, and strong leadership is the way forward. I like to put Florence in as well because we're nurses, and this is really important too. So Florence, even back as far as the 1800s, was saying, never let us consider ourselves finished nurses. We must be learning all of our lives. And we owe that. If we continue our professional development throughout our careers and regardless of which career path you choose, education and clinical practice together are so powerful. And I really feel that you should always continue education, regardless of your age or your post or whatever. So we need the skills and competencies to leave. We spend most time with the patients and know them best. Education and training will make us competent and confident, and I'm sure Phil is going to tell us all about that. But we need to have self-awareness, reflection and self-belief. And I think these are some of the things we struggle with, is the self-belief, how good we are as nurses and what the knowledge we have and how powerful and empowering that is. We just finished a chapter for the Springer textbook on palliative care with colleagues from the US and from Germany. And that has lots of really useful exercises you can do about your leadership skills and your management skills and so on. And finally, that is me in those old days back at the Royal Marsden in London. And thank you. And that's my email address if any of you wish to contact me. So thank you very much for listening.
Thank you very much, Julie, for your very nice presentation and your insights into the importance of leadership for the timely start of palliative care and nursing in general. I'm Vereecke, and I'm the coordinator of the 2 ERASMUS projects that we will deal with later during this webinar. It is my turn to welcome you to this first dissemination webinar. And it's my great pleasure to introduce to you Philip Larkin. He's a professor in palliative care nursing at the University of Lausanne. Philip has worked in palliative care as a clinician, as an academic, and as a researcher. So he has extensive experience in undergraduate and postgraduate education. Philip, we're really looking forward to hear your perspective on the importance of palliative care in the education of nurses. You have the floor.
Thank you. So, hello everyone, and I'm delighted to be here. They have to actually advance the slides for me because unfortunately I can't do it from on a Teams meeting from Switzerland. So I'll be telling them to move the slides. And I wanted to first of all say I'm so delighted to be here. It's such an amazing opportunity to see how things have developed over the years in nurse education in palliative care. And I wanted to look at palliative care education from 3 perspectives, if you like, the past, the present and the future, and try to think about what are the things I've learned from my years of practice. Julie and I are contemporaries. We were at the Marsden at the same time, which means we're of a similar age. And that's an important element here because many of the people who were initially involved in this work are coming to the end of their careers. And the question is, where will we find the next generation to lead education and lead palliative care nursing? Can I have the next slide, please? So what I want to do really is to try and address 3 questions. What has the past taught us about how nurses were educated in palliative care? I then want to look at that. How can we embed the learning from education to be effective nurse clinicians? One of the great benefits of my career is I always tried to get a job where I had 1 foot in clinical practice and 1 foot in education. And even if I wasn't able to see patients all the time, I would try to work with nurses to make sure that I always kept my clinical skills up to date. And that's a really important message, I think, for the way we actually train nurses in the future. How do we make them clinically effective in what they do? Because nursing has, of course, changed dramatically from the way it used to be. And now we're looking for people who have autonomous professional practice where they can take on the leadership roles that Julie has presented to us just now. And finally, I want to talk about what do we need to do to establish a future nurse education? What are the components of nurse education that might be important for the next generation? Next slide, please. Oh, sorry, you can go to the next one. Thank you. Next slide. So I suppose we have the great picture of Cecily, which I found as well. And I think it's important, if you look at the letters of Cecily Saunders, in the very beginning of this very important book, she had 2 books where she talked about, her vision for palliative care. She makes a statement that in many ways, palliative care is just good nursing. So she places nursing very firmly centre for the delivery of palliative care. However, nursing traditionally, and certainly in my time, came from what we used to call the vocational script for palliative care nursing, or the vocational script, which meant that we were very much seen in that caring role, supportive role, a little bit very much like the picture that Julie showed of the nurse. For some of us, our training tended to emulate that particular view. We were certainly not necessarily considered to be leaders, except in our own unit. If you were the ward manager, you led that unit, and that was your extent of your leadership. But to some degree, the way in which we taught nurses was around the elements of care, comfort, and compliance. Now, don't get me wrong, Cecily Saunders was really an amazing woman and what she did. And I agree with Julie that her view, her nursing skills have to have threaded through the way in which she saw the world. But I think it's also important to know that Cecily's view of what palliative care nursing was came from her observation of religious sisters, particularly the Sisters of St. Joseph's Hospice in Hackney, where she spent some time. She also linked with the Sisters of Grandvaux here in Switzerland. So she had a vision of what she thought palliative care could be, which to some degree supported this vocational script. And in the early development of palliative care nursing, we can see that that seemed to play out a little bit. The people who were invited to set up hospices and work in hospices sometimes came from that group of that development. Now, I also want to say there's nothing wrong in that. There are elements of that that are extremely important. But if your education is only based on care, comfort and compliance in the sense of doing for others, then you miss something in where we need to go with the next phase of our work. Next slide, please. So the other challenge I think we have in the past is that the evidence base for what palliative care nurses do is still today rather limited. There has been some work. We still tend to talk about this. On the right of my screen is the circles, which is the Davis and Oberle study that was done back in 1990, where they talked about the various functions of the palliative care nurse. Now, what's important to remember is this was a study where they observed one nurse in practice. It was an ethnographic observational study of a palliative care nurse. But for many years, that was the only evidence that we had about what palliative care nurses actually did. Subsequently, as nursing developed and we saw the role of clinical nurse specialists and eventually advanced nurse practitioners, we saw a shift where people started to talk about issues of leadership and expertise and how we work in that interdisciplinary way. But to some degree, I would have to say that our evidence base about what a palliative care nurse does is still limited. And I'm really hoping that EduPal is going to address that. The NursEduPal program will address that. Because I think one of the great challenges that we have is, what do palliative care nurses do, which is different to any other nurse that cares for somebody at end of life or in the palliative care phase? And this is particularly important as we talk about early palliative care, generalist palliative care, those who work in the actual discipline of palliative care as a professional specialty need to be able to articulate exactly what they do. You might need to press it again, Joanne, because there should be another little picture, and there it is. So the other thing that's very important that we need to remember is that often our exposure to patients and families is still around end-of-life care and death and dying. And that's a really important thing that we need to teach nurses, particularly because they are the 24-hour, 7-day-a-week person by the bedside with the patient. And we need to ensure that our education teaches nurses how to articulate the language of death and dying. I'm not suggesting it's not responsibility of other professions, but we have a unique opportunity because of our proximity to the patient, particularly at those difficult and sensitive moments of life. I'm thinking of that first picture that Julie showed. What would the nurse be doing? What would the clinical skills that she would bring there in terms of enabling these people to understand where their life was now and what may be happening to them? So our education needs to think about that very broad range of knowledge and skills and attributes, but also never forget that this may be the important element we need to share. Next slide, please. So the other thing is, a really bad photograph of me, but there's a reason for it, is we talk a lot about preparation for practice. And I think that one of the things that nurses have often done and still do is how in English we call honing our craft. It's the work you do if you're making something in wood. You use an implement to hone the wood. We have to. How do we bring the theory into practice? One of the great challenges in academic nursing is that academic nurses tended to live in academic worlds and lost the link to the clinical. And I'm sorry if I seem to be banging a drum about this, but I think it's really important for the future of palliative care nursing practice. And you see, I have a picture of myself here. I'm with colleagues from Ireland, actually, and we're in Belarus. We're in a children's orphanage in Veshnova, where we're trying to help them to develop some palliative care interventions for children with chronic life-limiting illness. And there's also other images here at the bottom on the right. This was a really lovely book that was done in Ireland some years ago called Helping Hands. And it was a nurse photographer who took images of nurses in palliative care doing actions. So the thing is, how does our ivory tower education make sure that we've prepared people for practice, that we can bring that knowledge and they bring those skills with them? And some of that is around coaching, so that there is a clear pattern between theory and practice. And that is really about how we coach people in the field to become expert practitioners. And I think that that is a skill that palliative care nurses can develop more. How do we develop people's, we identify something that they're particularly good at. How do we strengthen that? How do we make that grow? Next slide, please. So that's the past a little bit. So how through education can we embed the learning that we need? Next slide, please. So I think we need to talk a little bit about advanced practice. Advanced practice has come in various places a little bit late. I have to say here in Switzerland, where I'm based, advanced practice is really quite late. It only has started in certainly the French-speaking part of Switzerland since 2018. And there's quite some diversity as to what we mean by advanced practice. But it's very clear that based on the data that Julie has shown earlier, if we don't develop nurses to work in these autonomous advanced practice roles, our healthcare system and our care for patients and families in the future will suffer because we will not have enough practitioners. And so we need to recognise both the expertise of the nursing profession and how to create dynamic training programs that enable them to develop these skills, to take these skills forward. We know that for people who develop advanced practice roles, they often seek different career enhancement. So they look for different roles and different functions. But we can also strengthen recruitment and retention by ensuring that employers offer people the possibility of advanced practice roles and give them the skills and the autonomy to do the job for which they are prepared. Within that, then, I think we also then need to consider who are the population in the future that we are going to be caring for. Traditionally, when I was a palliative care nurse, we focused very much on cancer patients. And although I think we have tried to shift our thinking, and WHO has really tried to push us in this direction, the reality is that for many services across the world, their function and their role is still focused towards cancer patients. And other patient groups may have some engagement, but it still tends to be a cancer population. Next slide, please. So I think that if we're looking at what we need to do with our curricula, it needs to be a responsive curricula to the current realities. It doesn't mean we forget the past. There are elements of the past that are important, but how do we bring this into the real world? And I think, for example, what are the growing global health challenges? The issues of serious health-related suffering. I was recently in Brazil at a conference, and I met an amazing advanced nurse practitioner in palliative care who is providing a service to people in the favela, in the poor shanty towns in and around Rio de Janeiro. And you cannot imagine how the lack of infrastructure there, and yet the work he is doing is quite phenomenal with a team. He's not on his own, with a team. So nurses in palliative care are looking to address these problems. We have a fragile aging population. We have to deal with comorbidity and chronic illness, which is rising. How well do our curricula prepare nurses for that diverse range of needs? Are we focusing still on things that are so generic, it's difficult for people to take out of that what they need for their care? And the final point I would make there is still this contested definition of what palliative care is. We have public health palliative care, which has a slightly different view, I think, to WHO about what palliative care is. Public health palliative care is a really powerful message, I think, that we can imbue as nurses in diffusing palliative care into the community, into the population, and supporting them to help care for themselves. So there's really strong messages from that, but also to remember that organisations which might be more traditional in their view of what palliative care is may also have something to offer. So in our nurse education, we need to be open to possibility, open to the possibilities of where we can go with this. Next slide, please. So I wanted to share this model of advanced practice. This was prepared by developed by a colleague of mine from when I was working in Ireland, Lazarina O'Connor, who sadly died a few years ago. But she was she wasn't working in palliative care, actually. She was a pain control specialist, pain management specialist. But she developed this model of what she called universal collaborative dynamic specialist and advanced nursing practice. And I think there's some elements within this model that we can think about as if we are the people who are designing curricula for nurses. So when we design our curricula, we get very obsessed with our learning objectives, and we get absolutely panic-stricken about how many credits they get and whether this meets a particular requirement for the student and how many hours of work we want the student to do to achieve these credits, which is usually completely unrealistic. No reflection on the reality, as Julie has shown, that we're often working with, women who have many multitasking things that they actually have to do. And the reality is, and often working part-time. That's the other issue. Very few nurses often have the opportunity of higher education, and certainly not at a full-time basis. But I think that the elements on the inner aspect of this circle, I think, touch the things that we need our nurses to be able to do. They need to be able to work with a position of ethical comportment or ethical practice. They need to have the leadership that Julie spoke about. They need to have the capacity to consult and collaborate, so they become a conduit, if you like, a bridge between the various aspects of services. They need to have the capacity to bring research into their clinical practice. That's why I say having a foot in the clinical world and a foot in the academic world can help to strengthen that clinical scholarship. And they also need to understand their accountability, and accountability is about boundaries. What is the basis of my work? What is the role of others? So that nurses are not seen as I sometimes use the phrase, the mop and bucket that picks up everything from the floor because nobody else seems to be addressing it. And nurses often are very good at that because they've been trained to multitask. So these are just the sort of things that the list on the left is really what our managers want. They want the key performance indicators. They want the metrics. But on the other side, we need to think about these other issues that I think are really pertinent to how we create the next generation. Next slide, please. So the third part then is, where do we go next? What do we need to establish a real future for nurse education in palliative care? Next slide, please. So although the evidence base is somewhat limited, I think there's been some really interesting work. This is work by colleagues from Sweden, which tried to say what exactly is the nurse's role. And I've taken from that this phrase, which I think is where we want our nurses to be in the future in terms of their capacities. And that's a practitioner who is able to respond to both practical, relational and moral complexity, and so provide tailored and responsive care. If we can achieve that through our education and training, we will actually have established something really strong for the future of palliative care nursing. To be able to work practically, to use your hands, to be able to do the job that nurses are very good at, to communicate in a relational way, not just with patients and families, but with the wider team, to understand the complexity of the work that we do. And in order to do that, to understand what can I provide in this particular situation, in this particular context, so that the person has the experience of a tailored and responsive professional service to themselves. Next slide, please. So if I look at the traditional models of how we teach people palliative nursing education, and I'm going to say that when we did the original nurse competence guidelines back with the EAPC many years ago, this was the language that we used. So it was often about attributes. And again, that goes a little bit back to our initial talk about the past, what are the inherent behaviors, if you like, of the nurse that's in there that makes them the person that they are. How do you choose somebody to work in palliative care nursing? What attributes do they bring? But it also looked at knowledge and skills. The difficulty sometimes, I think, with skills is that it's judged on a particular act or action, but it doesn't always look at the rationale behind why a particular action is undertaken. So skills are important, but it's just, what does that mean? Being able, for example, to do a complicated dressing is one thing. Understanding why you need to do it in a particular way and how you need to manage that in a broader context is actually all part of that skill. And we were very focused on the patient, family and society. And I think, again, that still speaks to this public health message for palliative care. But also, I think it also makes us think, who is our patient? Who are their family? The idea of family is now much broader context. Society also touches into issues of culture and language, and how do we address those in our practice? So to some degree, when I looked at when I was involved in education in different countries, particularly when I was in EAPC, I would see this type of a framework within the way in which nursing education had been considered. Can I have the next slide, please? So I'm going to suggest to you that we need to just transform that a little bit. So some work, and particularly in advanced practice nursing, they've moved away from competence to capacity, the capacity for the expert practitioner to demonstrate their skills and leadership. And I think that's a really good way. So it's not, because a competence is I'm either competent or incompetent, and nobody wants to be incompetent. But capacity is a broader way of understanding this. We need people who've got really good judgment, and I'll talk about that in a moment. They need expertise. So we need to decide, what does expertise mean? And if I'm an expert in something, how do I share that with the wider community? What makes me an expert? And I think that's something that often tends to arrive for nurses, rather than being something that's actually placed clearly within, a clear module or a clear discussion around clinical expertise or clinical evaluation expertise. These things are really important going forward. Comportment is a word, an English word that covers many different things, but it's really about your behavior. It's about the way you present yourself. It's about the way that you carry out your professional duties. And I think that is really, really important. We know that for patients and families, nurses play a very significant part in their palliative care and end-of-life experience. And therefore, that memory will remain with them. That's what Cecily Saunders said in Julie's slide. The way you are can influence the way that an experience is perceived. So you really have to think about that. And within that, about that self-reflection is, if I'm having a bad day, is today the day I should be going to see X patient because I need some space? And that's a message also for the healthcare provider, not just the individual. I won't go into leadership because Julie's addressed that, but that leadership role is really taking into account all those other elements. Next slide, please. So at the end of the day, what we need our education to do is to give us practitioners who have critical thinking, and that also includes a self-reflective element. People who have good judgment, they can make clinical decisions, they can act on those clinical decisions, but also people who work from a perspective of wisdom. What is the right thing to do in this situation? Because we know in palliative care, sometimes the right thing to do is not to intervene. That's a whole ethical issue to address. But how do I use my wisdom, the wisdom I gained as a young nurse? How do I still bring that into my practice today so that as an old nurse, I'm still using those three circles in the way I think about how patients can be cared for better? Next slide, please. So to conclude my talk, next slide. I think for our future, we need a couple of things. I think we need a clearer understanding of who we are as palliative care nurses. And this is particularly, as I said, now in the light of the fact that palliative care has become a much broader public health based initiative and is talking about general palliative care and non-specialist palliative care. So what is our actual contribution? Who is a palliative care nurse these days? And what can we do and what can we do in practice so that we're very clear, we know what we're capable of, but what are we actually able to do? And how do we convince those people responsible for organising care and palliative care that we actually have a really important role within this? How do we recognise the hard-won gains? All of you are here today, and I know many of you will have struggled to get to the position that you're in because nursing was not and is still not respected in many countries. So we need to remember, and that's why being here today is so great, there are many hard-won gains, and being here is an achievement in itself. And I think that we need to take what we've done to be strong. As they say in French, they have a phrase which is strong in your boots. You need to be strong in your boots to support professional development and leadership into the future. I also think we need to look very carefully at how we support and incentivize nurses to take on higher roles like advanced practice, but also higher studies. One of the great challenges that we're going to have is there are very few PhD prepared nurses in palliative care. Those of us who are there are retiring soon, and we have no one to come and pick up that work. So how do we ensure that people who've got a PhD are given the opportunity to share that within the clinical community, but both to bring that academic and clinical together? And that's why I feel very strongly that our education needs to favour both clinical and academic role development for nurses. But I also think we also have, and again, I come back to this project here, is to provide a clear language for better international collaboration. Because if we can understand who we are and what we do, and we can stand on that platform, then the reality is we will have better nurse education, better clarity for people out there who may not understand why we need a nurse education, and finally, optimal practice. We will improve the care for the citizens that we look after. Next slide, please. And finally, this is my last slide. I want to come back to, I use this slide a lot. So Henri Nouwen is a philosopher and theologian, and he's written lots of books. Many of you may have read The Wounded Healer, but I do a lot of work around compassionate care, and he wrote this little book about compassion. And in there, he said, a compassionate response is within you because you are the difference you make. And the reality is every day in every action in your nursing practice, you are the difference that you make. And if you remember that, it will enable you to see what the future can be. Thank you for your attention. Again, I've got my email there if anybody wants to follow up on anything. And thank you for the invitation.
Thank you, Phil, for a great presentation and your thoughts on the past, present, and future of palliative care nurse education. I think I'm happy to see that with the NursEduPal Impact project, we seem to be on track, at least to be in line with some of your proposals for the future. So before we proceed with the last part of the webinar, I would like to ask everybody to share your thoughts with us. We would like to ask your input on how palliative care education or practice is organized in your country. So I would like to ask everybody to write in the chat, not in the Q&A, but in the chat, 3 challenges and 3 opportunities in your country on palliative nurse education and or palliative care practice. So I will give everybody a couple of minutes to write some things down. If you don't have 3 opportunities and 3 challenges, doesn't really matter. Whatever you want to share, please do so. Also, maybe write your name and the country you are working at, so that we can kind of have an overview of who is saying what. And the idea is that we will try our best, that with the input we get from you, to take that into consideration in the upcoming teaching webinars and in the development of the teaching materials. So we'll just give you a couple of minutes. Maybe I will start already. Okay, so I see already some information popping up in the chat. Thank you for that. But just to keep track of time, maybe I will start with the last part of this webinar. And it's my pleasure to explain to you the essence of 2 NursEduPal Erasmus Plus projects that we've done with this team. So the NursEduPal at Euro project ran from 2020 to 23, so it is finished now. And it was a strategic partnership between the Transylvania University of Brașov in Romania, Camp University of Applied Sciences in Kajaani, Finland, and West University of Applied Sciences in Belgium, together with the European Association for Palliative Care. And the target of our project was nurse educators mainly, and through them reach the nursing students. And what we wanted to do in that project was to provide a set of European core competences, so basic competences in palliative care for all healthcare providers, but nurses in specifically, provide a European matrix for palliative care education, so teachers could build their own curriculum, and to provide ready-to-use teaching materials. Teaching materials that were immersive and engaging, and thus a little bit innovative for palliative care teaching, maybe. So with all of that, we wanted to provide resources for nurse educators so that they could develop and strengthen their competencies to provide better education in palliative care. And by empowering the teachers, the idea was that the nursing students would be better prepared when they would enter into practice. So here you have an overview of all the outputs that we've generated in that project. For the sake of time, I will not go into detail in it. The slides will be shared, and you can still download all of this information for free from our project website, which I will show at the end of this presentation. But here you kind of see a graphical overview on how everything kind of came together in that project. So we had the core competencies. We provided realistic cases on different palliative care situations. These could be used as input to have realistic teaching on palliative care with all the different tools that we've developed. And then with the framework, you could use these tools to build a curriculum, or at least a course, an interactive course with your students. And we also wanted to build a network of educators. And through this whole procedure, we wanted to, you know, have students that were not dropping out of nursing 2 years after they graduated. That was the idea. But the thing is that you can, you know, have very engaged teachers and very well-trained students. The reality is often when they come into practice, that the people they are working with or the circumstances they enter, they don't allow them to implement all the skills and all the knowledge and all the proper palliative care attitude that they have. Because the situation is just not permitting that. So we thought that this was really something that we wanted to tackle. And so we were very happy that the ERASMUS allowed us or funded our follow-up project that started in the end of 23 and will finish at the end of 2026. And our target group there are the nurses in practice, because we want to get them on the same page as our teachers and the same page as our students that are graduated as fantastic palliative care nurses. And so what we want to do there is we want to build further, of course, on the NursEduPal at Euro outputs, because we have all those materials there. And again, we want to provide ready-to-use learning and training materials and also a learning trajectory through which you can grow to influence your environment. And so what we want to do with all those materials is we want to improve knowledge and self-efficacy in palliative care. We want to improve leadership in palliative care so that you can influence others to improve the integration of qualitative palliative care into your daily practice. And this is the approach of our project. Of course, I will go a little bit more into detail in NursEduPal at Impact, because we are still doing that project. So we want to work on the 3 levels of leadership that are important in nursing: clinical leadership, moral ethical leadership, and professional leadership. And we want to work on 3 levels that will allow you to demonstrate that leadership. So you need to have some knowledge, you need to believe in yourself, and once you do those 2 things, you need to get trained into influencing others to integrate palliative care as well. So, and this is the trajectory that we kind of set out. We thought that we don't want to slam people with a whole lot of knowledge, so, you know, that they lose their self-efficacy because they think, oh my gosh, I'll never be able to do it. So we want to give them the minimum but essential information and knowledge that they need on the 3 levels of leadership. And so for that, we will make 6 e-courses and 6 syllabi that go with that on clinical leadership, 6 e-courses and 6 syllabi that go for professional leadership, and 4 e-courses and 4 syllabi that will go on moral ethical leadership. All of these syllabi and e-courses, they will be available through our website for free, and we will also do teaching webinars with them. On top of that, we will provide supportive materials that will allow you to train the knowledge that you have gained. So this is work package 2. And once you've done all of that, you are ready to go from the inner circle to the next circle. And in the next circle, we work on self-efficacy. And for that, we ask input from our communities of practice. Our communities of practice are teachers, nurses in training, and nurses in practice. We already did an online survey where we gathered stories from nurses in practice, where self-efficacy and moral dilemmas either hindered or just stimulated them to provide good palliative care. We are also going to organize focus group very shortly. And with that information, we want to build at least one, or maybe more realistic, complex cases in which self-efficacy is the centerpiece. And then based on that story or those cases, we will build all these impact tools that will help you to train your self-efficacy. And then we are going to train teachers to work with all those impact tools. And once they are trained on how to do that and how to train people in leadership, they will all go back to their countries and they will organize an impact week where they will have learners, can be nurses in practice, nurses in training, where those will be trained with all those materials. And so once they've done that, they will have completed the second circle in our model. And then they will be ready to go to the outer circle. And to do that, we will just gather everything that we have into a nice and attractive handbook, a manual for teachers, training of trainers, so they can implement all of these things into their own working environments. And we will also, in the 3 countries that we are working, so Romania, Finland, and Belgium, we will have maximum 5 members of our communities of practice that we will mentor for 6 months. So we will follow or guide them into becoming palliative care influencers in their setting, and make some kind of improvement to have better palliative care. And we're not looking for like the biggest improvements ever. It can be something small, but something that will really have impact. And of course, we want to come out with all of this stuff. So we will have all our materials available through our project website. We have the dissemination webinars like we are having today. We will have a couple of more during the project. We will have 16 teaching webinars, and I will come to that back in a minute. And we will also have an international multiplier event at the end of this project. So our communities of practice, we are just reaching out here to all of you if you want to be a member of our community of practice. What do we want from you, and what will you get? So we want you to get involved, to co-create materials together with us, teaching materials, or to evaluate the materials that we are developing, or to test them out in your setting. Do they work or not, and should we change something? We want you to attend the teaching webinars, but maybe also to present the teaching webinars. That's an opportunity too. We invite you to participate in the Impact Week, and some of you might be selected to be coached for 6 months and become a palliative care influencer. So if you are interested in becoming part of one of our communities of practice, please do contact us. The project website is given here, and here you have our email addresses from the 4 different organizations that are involved in NursEduPal at Impact. And so what's next? So we've been talking about those teaching webinars quite a bit now. So I'm happy to say that the first series on professional leadership in palliative care has been planned. So it will be a series of 6 webinars, on the dates that you can see here. And they will all start at 2 p.m. Central European time, and they will last, it will take 1 hour each. And again, every time you attend one of those webinars, you will get a certificate of attendance. And if you've attended everything, you will be able to call yourself on the way to become a palliative care influencer. And I think that was my last slide. Yes. So with that, I think it's time to do the, let me just see to stop sharing. Wait, here, okay. I am happy to pass the word to Nicoleta Mitrea. And
we have questions in the chat for question and answer, so I will try to address as many as possible. So there is Nadia who is asking, I think, Julie, how can we strive to improve our leadership style when our colleagues are not particularly interested in it?
Well, I have to say there's one of the things that works very well is tenacity. That's being, she's there, great. That's being there. So I think that, I think it's a little bit what Danny was saying. I think the trouble is that sometimes we try to change the world when in fact we just need to change one step forward. So I think that in where you sometimes feel you're banging your head against a brick wall, you're not getting through the door. But you can find little ways to do that. So I'm going to give you a quick example of how we had some challenges where I am in my hospital, because it's a very big hospital and it has lots of different things going on. And to be honest, if I was frank, I don't think that the direction of nursing particularly understood what palliative care was, and they certainly didn't know what a professor of palliative care nursing was. But the way we got in was we developed a quality project around the way in which the body is transported from the unit to the morgue, to the chapel. Sounds a bit of a strange thing, but it needed to be improved, and we found our way in to do that. And once we found a small project that was allied to palliative care, people started to see what we could do. And that, I think, is it. So you have to be a little bit tenacious. You've got to be there and sort of, keep knocking on the door, but try to find some project which can benefit patients, and then the bigger organizations can see that you've got an added benefit, a real value.
I think that's a great answer. My leadership's so bad that I couldn't even find how to get the mouse onto the right buttons on Teams. Hence, I was listening. Okay, so I think what Phil says is exactly right. So you're not going to change the world in one day, and it's sometimes the smallest of things. And you can't change other people. You can only change their opinion of you. So doing a small project, doing something that often in organizations will save time or money, and demonstrating that clearly. Sometimes that's beyond the scope of your role. But one thing I think that I know you're saying that I can see there's from Malaysia, and I'm Dr. Shani as well. I'm not sure where you're from, but I can see that you're saying the same things, which is, that nurses aren't valued as leaders. And I think that that's very, very difficult, but we were all there. We started there, and it is making those small steps. And sometimes more safety in numbers. So if there's a group of nurses working together, you start a project, you look at something that will, for example, collect some data. We were talking, there's not enough evidence of what we do. So there's always things you can do. And I think you need to just think of a little idea of something. So, for example, if you're working in a home care team in Malaysia and you want to show something, why aren't you collect a little bit of data from your colleagues, put something together, put a proposal together to your manager and see what you can do. I think you can change yourself, but you can't change other people. So you just need to work and keep going. And I think knowing, as I can see here in the chat, there's other people in similar position, but I also see people in that chat who have made changes in their country, and I'm sure she won't mind me calling her out. People like Irina Laska in Albania, Nicoleta in Romania. There are people who have been in that situation where it's challenging and have made small changes. And that's what our leadership is. We're leading ourselves. We're making ourselves have confidence in yourself. I think Phil raised some interesting issues in his talk around, us not being sure what palliative care is. And the WHO, it's almost that first slide I showed you about, this is what I'm saying. That's why I have to say it every time. This is what the WHO definition of palliative care is. And one of the problems we have is around the world, everyone's at different stages. So it's good that we have a set definition. This is what it is. And there might be, ways of changing that a little bit about public health, palliative care and other things. But ultimately, if we change our definitions and we all keep saying different things, people get really, then the ministries of health say, but you're all saying something different. So we stick to the definition that is the WHO definition. I think for those of you working in isolation, you need to think there's ways to start things, and maybe these series of webinars, if you attend them all, you might find more little seeds of things that you can bring to your practice and be able to grow into something that makes a change and makes a difference to palliative nursing.
Thank you both. I will try at least one more question. to both of you. Interesting model of advanced practice, the one that you presented, Phil. Thank you. But what about research? Who do you feel should be conducting the research in palliative nursing?
For me, it's the nurses in the unit. Okay, so I think at the end of the day, for nursing research, nurses often have hugely innovative ideas because they're by the bedside. So you need to have somebody who has expertise to take those ideas, but not to take them from the nurses, but to give the nurses the skills and capacities to be able to develop those projects themselves. Because the problem is that often nurses see research as something out there that really is not relevant to them, or that their only role and function is research is to identify patients for somebody else to do research on. So in fact, we need to develop collaborations so that the actual real ideas come from nurses, but that we also give nurses the skills. If you think about it, many of the things we need to know about patients, we can find that information through interviews. We can find that information through communication. Nurses are so skilled in that. They are extremely capable. And I've worked with many nurses who, but often they think, oh, I'll just talk to the patient and give you the interview. Can we develop research networking with our clinical colleagues if we work in research, to give them the skills to carry the torch forward? That would be my big thing.
Julie, will you have another?
I think I agree completely, and I think the smallest of projects, even I know when I was first started undertaking research, a lot of what I was doing was audits, and they're not really research in pure research, but even if you can have evidence of what you're doing and looking at what you're doing in your clinical practice every day, and documenting that, because a lot of people don't even collect that kind of data. I mean, some of us have very complex systems that can collect data, but you know, collecting, and that actually adds to your case and your argument for what nurses are doing. I mean, I think that's always a very simple way to start. And I think when you look from the scale of people who do no research right the way through to these really skilled nurses who have big research grants, you can see everyone starts from these little seeds, and that's what you need to think about. It's starting from the ground up. And we know what the issues are. Sometimes research projects seem to not really relate very much to what we're doing in clinical practice, but actually working so closely with people and their families shows us what the real issues are and what needs to be addressed. So I think we're in a really ideal position.
Thank you so much. And one last question for you, Julie. How can WHO help to develop nurse leaders in palliative care?
Well, I think as I see, there are nurse leaders in palliative care. I agree with Phil. Quite a lot of them are in our age category, so we need the people to come behind us. And for that to happen, I think that's part of leadership, is that you actually bring people along behind you so that you know when you're going. So I think it's about promoting your colleagues and developing them and giving people opportunities, because sometimes it's very easy to just do things yourself, but actually it's about bringing people behind and developing. So that's how we as nurses can develop. And I think what's really important is always to bring people along the path with you, not pull the ladder up behind yourself when you're promoted, but to actually look at who can you help and who can you develop. And that's, I think, part of our continuous learning that we should all be doing, is helping. I think from here in the WHO, we work with different governments of the 53 member states, and nursing is really big on the agenda at the moment because it's such a vital service. And, you know, so many nurses are leaving the profession. Some never work as nurses. And so I think it's around looking at career pathways, looking at leadership. We do lots of different courses in different countries on Train the Trainer, and bringing people up and doing the Leadership Academy. We're trying really hard to encourage people, but also the WHO has an advisory role. It's not, we can't go to a ministry and say you have to do this, but we advise on best practice and how they should do things. So it's really making nursing attractive and looking at things such as remuneration and career pathways, and ensuring that people have promotional opportunities. And I think if we can do that, then that will really help with nurse leadership across the board. And I think, you know, there are really good examples. Even in the chat, I was looking, and you can see, I think someone wrote in the chat about the UK and nursing, advanced nurse practice roles and things. That's the way we need to go. And so we're always working with all the different member states to look at what we can do to help. And I think also I as a nurse and as a palliative care nurse working here have the opportunity to influence and impact as well, I hope. So
yeah, definitely. Yeah, thank you
Anyway,
so much, Julie.
Thank
and
you.
The last question of this webinar is addressed to Danny. Will this Train of Trainers manual handbook be available for anyone?
Absolutely. Everything that we do is available for everybody for free. This is how we want to influence and how we want to impact. So whenever, of course, that will be at the end of the project. So you still have to give us a little bit of time to work on that. Yeah, absolutely. And it will be available in 4 languages, the languages of our partnerships. So English, Finnish, Romanian, and Flemish. But now
thank
with
you so
AI,
much, Danny.
you can probably translate it into any language you want.
Yeah, thank you so much. And I think we reached the end of the webinar. We are so much grateful for the opportunity that we have had. For me personally, it has been just a joy and a privilege to have both Julie and Phil as presenters. So it was my Christmas present from the professional point of view. So thank you guys for just sharing freely your time with us. We know it is so valuable, so we don't take it for granted. So thank you so much from the bottom of our hearts. We'll keep in contact with each and every one of you, and hopefully our community of practice will enlarge, and at least it will be one small step that you feel and you, Julie, mentioned that we need to make in order to make bigger changes. So we'll do our best. Thank you so much. Have a great evening and great celebrations for winter.
Thank you. Take care. Bye-bye.
Goodbye. Thank you.
Bye-bye.
Thank you.
Bye-bye.